So it's really in everybody's interest to solve this problem. It shouldn't be a political bipartisan divide. There is a solution out there, but you need a bipartisan consensus with the business leaders and insurance companies at the table to come upon an agreement.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. We're honored to have Dr. Paul Convery for a special edition of the Business of Healthcare podcast. Paul has over 20 years of experience as a senior healthcare executive, serving in a variety of leadership roles. His background and expertise covers a wide range of clinical and administrative roles, serving as the president of 2 hospitals in the St. Louis market and also the past chief medical officer for Baylor Healthcare System in Dallas, Texas. He's currently a clinical professor of healthcare leadership and management at the University of Texas, Dallas. Welcome to the podcast, Paul.
Bob, thank you. It's my pleasure to be here.
I mentioned that this is a special edition of our podcast. You recently presented on a panel here at UTD with other panelists who are involved with hospital and insurance organizations to discuss the topic of Medicare for All. We hear about this generic term, Medicare for All, and it appears to be a very complex topic. Help us understand some of the history, details, and public perception.
Well, Bob, Medicare for All is a complex topic. Healthcare is complex, and the financing of healthcare and how people pay for healthcare is very complex. And in this country, that system is basically broken. Medicare for All first came into the public discussion in 1970, and it was introduced by Senator Jacob Javits, a Republican senator from New York. You can go back as far as Harry Truman and hear presidents talk about a national health care policy, but it's never really caught on with the American public and with the voters until the last decade. And in the last 2 or 3 years, multiple surveys show that about 60% of Americans favor a Medicare for All or a national health care policy approach. And that is dramatically different from the last 50 years.
So when I hear the word Medicare for All, the word Medicare stands out. Is there just one flavor of this Medicare for All, or does it represent itself in different forms?
Well, it's really evolving. And there are, I believe, 10 or 11 different bills submitted in this current legislative session that cover the range of Medicare for All proposals. They range from the single national health insurance program that we hear most about, that is sponsored by Senator Bernie Sanders, and that's the whole deal. A national health plan replaces Medicare, Medicaid, replaces all private insurance, paid for by a variety of taxes, progressive income tax, employer tax, and goes on. And it covers everything for all Americans, even dental coverage, vision, nursing home, long-term care, and it's all covered by the government. That's the whole big picture Medicare for All proposal. But there's others that are grouped into different categories. There's several different bills submitted by various senators that really offers a public option on the Affordable Care Act marketplace. That's a public option based on Medicare. So it's a Medicare-like proposal on the public option paid for by premiums and co-payments of the purchasers. There are subsidies for people below certain levels of the federal poverty level, but HHS sets the premium, negotiates the rates, and it makes it available. There's a Medicare buy-in option for people over the age of 50. They can buy into Medicare, and they can even buy into Medicare Advantage. And again, its rates are set by HHS. There's negotiated with pharmacy, hospitals, and physicians, and it has a separate trust fund. And then there's a Medicare for America Act of 2019, which is a proposal that everybody is covered for this unless they opt out for the employee-based insurance. And then there's a Medicaid buy-in option the states can offer through the ACA. So there's a whole series of proposals that Congress has before them. Now, these won't be acted on this congressional session. This is more of a menu than anything else. But what they all have in common is they except for the single national health insurance plan of Senator Sanders, they all have in common that they leave private insurance in place, allow employee-based commercial insurance to still exist. They set a negotiating policy or a standard or a pathway for the federal government to negotiate prices for hospitals, physicians, and pharmacies. And they have certain levels of cost sharing and subsidies for people below a certain federal poverty level.
Okay, so I'm hearing there's like 5 or more proposals that really fall underneath this rubric of Medicare for all. And I think it's important to recognize that most of the people may not even be familiar with Medicare, and that population would be affected by Medicare for all, like the first proposal where you said everybody, all U.S. citizens are covered. So can we expand just a little bit on what Medicare is today for the audience so they understand clearly what Medicare really represents today?
Well, Medicare is a government program that was put in place in 1964 that covers all citizens over the age of 65. And then there's ability for people with disabilities, chronic renal disease, et cetera, to also get into Medicare. It's run by Health and Human Services, the division of the government, by the Centers for Medicare and Medicaid Services. You might hear it referred to as CMS. It's paid for out of a combination of taxes and premiums that Medicare beneficiaries pay. It provides these services that are for hospitals. There's a Part A that covers hospitals, Part B that covers physicians, and then there's a Part D that covers pharmaceutical prices, and then there's a Medicare C, which is a private plan option where Medicare is run by private insurance companies, and that's what people refer to as Medicare Advantage.
Okay, so 5 different proposals out there, and within the infrastructure of Medicare, there's all kinds of ways this might be mixed and matched. The first proposal you talked about for all U.S. citizens, there's no premiums to be paid, there's no cost sharing involved. I think everybody would say, that sounds terrific. Is there a tax consequence potential with that, or what's the backstory on something like that being received?
Well, that's the single national health insurance program sponsored by Senator Sanders, and there's multiple other co-sponsors now. Yes, there's multiple taxes that would pay for that, and that's probably the heaviest lift. We basically pay in this country about $4 trillion for health care, one way or the other. The federal government, combination of federal government, state governments, city governments, and counties pay almost $2 trillion for health care through Medicare, Medicaid, multiple other health policies, buying insurance for their employees, et cetera. The other $2 trillion is paid for by the public. $1 trillion is paid for by employers, and that's the premium that they pay for health care. And $1 trillion is paid for by the general public out of pocket in co-pays, deductibles, non-covered items. And so what the single health insurance program would do is transfer that entire $4 trillion, or the great bulk of it, to a government program. The trade-off, of course, is raising taxes. So you're raising taxes to the tune of well over $1 trillion a year, and that's the list of taxes that Senator Sanders has in a white paper on his website, which include a progressive income tax, employer tax, et cetera. And that's a big trade-off. I mean, economically, you can see where the money is moving. Philosophically, that's a heavy lift for any politician in the United States to raise that much taxes, no matter what the benefit.
Well, I know that for a fact that there are problems with our healthcare system today. You see all types of information. Recently, we interviewed Dr. Marty McCary, and his new book, The Price We Pay, uncovered a lot of different issues that are of concern. What problem are we actually trying to solve here? What is one of the biggest problems that we're trying to solve with a new approach, maybe using a Medicare for all?
I think we're trying to solve 2 fundamental problems. One is access of patients to services and the ability for them to get services. Now, access includes not only having insurance, but having providers, physicians, and hospitals that will take insurance. And even after the Affordable Care Act has been implemented, there's still 28 million Americans that don't have health care insurance. So the Affordable Care Act went a long ways towards trying to fix the access problems, but it didn't address the cost problem. And the various Medicare for All proposals, including the public options, and there's several different ways that could be implemented, start to also get at the cost problem. So we're trying to address both the access to care and the cost of care.
Well, that kind of brings up a big question, and the question that's asked over and over again is, how much do you want to pay for your health care? And I think it's almost impossible to answer that question unless you know what the price is. So transparency, is that an element of Medicare for All? Does that improve transparency?
That's not necessarily baked into these individual plans, but there are several federal agenda items that are trying to promote transparency, and transparency is being promoted by the business community and specifically by a RAND study on hospital cost transparency. Right now, the patient is at a total disadvantage when they go to a hospital, an emergency room, and even most physicians in terms of what they're going to pay. And so transparency is clearly part of this solution.
As we look at that topic of transparency, particularly when it comes to hospital care, prices within hospitals are never shown publicly to anybody. Is there some approach? Right now I'm hearing legislation in some states where they're starting to, on the local level, not the federal level, try to address some of these problems of understanding what the prices are that you should be paying.
The various states that are promoting this, what they are generally asking hospitals to do or telling hospitals to do is to be transparent about their charge master. Now, this gets into some of the technicalities of how hospitals bill, and they have a charge master, which is their master list price, the maximum price that they charge for their services. However, the price you pay as a patient will vary considerably. If you have health insurance company A, you might pay 20% of the charge master. If you have B, you might pay 30%, or you may pay a totally different price. If you don't have insurance, you may pay the entire charge master price, which in most cases is very high, and that's why you hear about out-of-network patients going to emergency rooms or having an out-of-network service and are charged very, very high prices for services, and they had no idea they were going to be paid for them before. That's this whole question around surprise medical billing, which is such a hot topic today.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So in Medicare, pricing has been pretty well established. The government's done a pretty good job of establishing pricing for most healthcare issues, except for what, pharmacy?
Yes. Medicare sets prices for hospitals, and it sets prices for physician services. By law, it was prohibited from negotiating prices for pharmaceutical companies. And that happened when Medicare Part D was passed by George W. Bush administration in the early 2000s. Initial proposal was that Medicare would be able to negotiate with pharmaceutical prices to basically set an agreed upon price. There was an intense industry lobbying effort to prevent that, and Congress actually wrote into the law prohibiting Medicare. So there's actually a law that prohibits Medicare from negotiating pharmacy prices. And thus we've seen very, very high pharmacy prices.
Yes, we have. So in general, Medicare is liked. The people that are in Medicare, they like Medicare, generally speaking?
Patients who have Medicare have a higher satisfaction rate than patients who have commercial insurance.
Okay. If changes were made to be more like Medicare, how would that impact organizations like insurance companies?
Well, it depends on how it is set up. Now, of course, under the single national health insurance program, all those insurance companies would go away. Now, you have to realize that the insurance industry in the United States is a $600 billion industry. So thinking that you're going to pass a law and take apart a $600 billion industry is a heavy lift. That's a bit of a stretch. If you have the Medicare option programs, several of the proposals would work through insurance companies, such as Medicare Advantage or other models. In fact, if you look at the other 12 or 14 developed countries that have a national health care policy, almost all of those work through private insurance companies. There's only 2 that are actually totally administered by the government. They all have a role for private insurance companies.
So the case might be that insurance companies may not be in favor of such a plan as Medicare for All, the first category that you defined. What about hospitals? How would they view a radical change, migrating more towards Medicare for All?
Well, the American Hospital Association has stated that Medicare currently covers only 87% of their cost. So if that's a reasonable number, and that's a number that's been repeated for the last couple of years, if that's the right number, the reciprocal of that would imply that about 115% of Medicare cost would cover the business of hospitals. And so that might be considered a starter for a fair market value. The RAND study on hospital price transparency that came out earlier this year shows that for the same Medicare medical service, commercial insurance companies pay, this is the price they pay, not the charge, pay hospitals anywhere from 240% of Medicare rates to, in some cases, up to 1,000% of Medicare rates. So there is some space between that 115% number and the 240% number or the 1,000% number to agree at a negotiated level that could help control prices, help patients get better health care at a reasonable price, and allow hospitals to still cover their costs and survive and serve the public.
I heard one of our hospital executives recently say that we provide health care for Republicans and for Democrats. This should not be a political issue of how we deal health care in our country. And so when you stop and think about some of the important aspects of providing this type of health care services, you find that there could be a trend where this is favored by some and not liked by others, really trying to address the issues of education and some of the social determinants of health care. Looking at the government, the federal government, to solve these problems is quite often challenged by industry. Industry looks at different things. We hear about Walmart and CVS and other organizations trying to address primary care, trying to provide pricing transparency so you know what to pay for things. I think there's a Surgery Center of Oklahoma that publishes information regarding the exact cost of surgery. How does that fit into this public opinion, if you will, of where the problem will get solved?
Well, the public is split on this along political lines, as you may imagine. On the all-in Medicare for All program, it shows generally a slightly favorite, 51% in favor of it across all parts. Heavily Democratic favor, weakly positive independents, and very poor Republican support, as you might imagine. On the Medicare public option, surprisingly, 41% of Republicans support a Medicare public option in a recent Kaiser Family Foundation poll. So there is a place for a bipartisan support around this, if we could imagine a bipartisan solution to health care around a public option, possibly engaging private insurance companies, maybe through a Medicare Advantage plan, and allowing commercial plans to still operate where they want to operate. And then you would have to have a place in the plan for this transparency around true costs. And that's really in the business interest of the employers to understand what the cost is, because the employers have no idea what the cost is. They just keep paying more and more premiums. That is impacting their global competition, and it's also impacting the wages that they can afford to pay for their employees. So it's really in everybody's interest to solve this problem. It shouldn't be a political bipartisan divide. There is a solution out there, but you need a bipartisan consensus with the business leaders and insurance companies at the table to come upon an agreement.
For sure, there's a cry for help out there, the high cost, the need for coverage. And as you mentioned, the employer has a bucket of money. That bucket of money covers their salaries and health care. And if health care goes up, there's less money for wage increase. So obviously, those are very, very important considerations as we look at the marketplace. Politically speaking, the elections are coming up here again. It seems like every 4 years we go through this routine. Do you see this as something that will be addressed or resolved during this current administration, or will it be kicked down the road a little bit further?
Well, I don't think it's going to be addressed during the next year and a half of this current administration. I mean, there'll be some pieces being addressed, and actually CMS, Center for Medicare and Medicaid Services, is moving a lot of their agenda in terms of trying to control costs and prices, and they're actually borrowing heavy from elements of the Affordable Care Act. They're implementing pilots and programs around accountable care organizations with upside and downside risk. They're implementing a number of proposals around bundles of care, which will help to control cost. And so they're leaning heavily on initiatives of the Affordable Care Act to do that. And some of the other initiatives that have been proposed, although they've been by executive order and haven't been implemented, are around transparency on pharmacy costs, transparency in advertising and what drugs actually cost, expanding Medicare Advantage to cover telehealth, all things that will lower cost. But I don't think we're going to totally solve it during this administration. And whether a future administration solves it or not will depend upon the sentiment of the public and how much the private sector moves. I mean, by that I mean pharmacy, hospitals, and insurance companies move to try to address this problem.
Well, it's pretty clear that it should be no surprise that this is a major topic now. When we look at some of the people that research the cost and quality of healthcare, like the Commonwealth Fund, where are we? Way down on the world rankings here still?
If you look at the 10 or 12 or 14 developed countries that all have national health plans and that report their data that can be comparable, we uniformly and have for the last 30 years ranked at the very bottom of these countries. Now, that's in total healthcare quality measures as a public health system across the country. We have pockets of excellence, and we have places where there's excellent care, but as a general, all the other developed countries deliver better healthcare to their entire population at about half the cost of American healthcare.
Well, we know there's an urgent need. I think starting in 2011, 10,000 people every day joined Medicare, and that'll continue on until the year 2031. It's a 20-year period of baby boomers signing up for health care. And if you look at the funding model for it, it deplenishes very quickly. So something has to be done. We can no longer just turn our back to this. It's such a big part. What is it now, 18% of the GDP?
It's about 18% of the GDP, yeah.
Yeah. So this definitely has to be addressed and has to be looked at. Your view on where this goes in the near future, obviously there's a lot of attention, a lot of people measuring and looking at this. Do you see this going away or just another political topic for right now, or do you see this as a very, very long-lasting issue that has to get resolved?
As long as healthcare costs keep rising at this level, an example, a family of four, their total cost for healthcare if they belong to a PPO, a physician-preferred organization insurance company, their total healthcare cost for a family of four, including premium, copays, deductibles, out-of-pockets, is $28,000 a year for a family of four. When the median income for that family in the United States is $60,000, you see that's unsustainable. And that healthcare cost has doubled in the last 10 years. So it cannot double in the next 10 years. There's going to have to be some lever, either a government lever or a private market lever to hold this down. And probably it'll be a combination of the two.
Very good. Well, Paul, thank you for your leadership in this topic. And I want our audience to stay tuned for additional information regarding the symposium we had here at UT Dallas on this very topic of Medicare for All. I think we'll be hearing more about it in the news, and it'll affect us individually as citizens, as family members, as community members. And so we should all get actively involved in understanding more and learning more and doing more as it relates to our health care. Thank you.
Bob, thank you very much.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.